Hello, everyone. My name is Caroline MacCallum, and I am so excited to be here presenting to you all. I can't see anyone. I hear there's a lot of people there, so hopefully you can hear me loud and clear. I am going to be talking about medical cannabis today, and it is a topic near and dear to my heart, as any of you I don't know if you've heard about me or been to our clinic. We've seen a lot of patients from Dr. Arsenault as well as from the CCDP. And just a little bit about me, I'm setting my timer. I'm trying to multitask here just so I don't go over. So I actually used to work at the CCDP many moons ago. I was saying to Rick, I think it was 10 years ago. So I trained with him as a resident, was very fascinated about groups. I attended his obesity groups and some of his other groups, and then started at CCDP, and then was there for a couple of years and got really excited about cannabis. My background is as a pharmacist as well as an internist, and I just really got excited about the pharmacology, and then I ended up diving into medical cannabis. So the majority of my career since I've graduated has been in cannabis. And I've also worked at the Change Pain Clinic. So that's another clinic in Vancouver, as well as I worked at VGH on the pain and addiction service. And I used to work at Heartwood, which is one of the inpatient units at BC Women's dealing with addiction. So I've also done bone marrow transplant at VGH, and I did some geriatrics at UBC. So I say all these things because I've got a lot of hobbies and a lot of interests, but this one happens to be one of my favorites. So I am happy to distribute the slides. After we're done, I'll pass them over to Rick. You can see my information is on this first slide, and I'll put it on the last slide as well, so in case anybody needs to take it down. This is a little bit of a bio here. It's very small font. Please, you don't need to read it, but if somebody wasn't able to attend or they wanted to refer back, I wanted to include it for completeness. But basically, I've seen probably close to 10,000 patients. I have worked with Health Canada. I've helped them with the revision of the Cannabis Act. I've done some court cases looking at cannabis impairment and safety sensitive occupations such as airports. I have published pretty extensively, actually. I've got over, oh, this is not updated. I've been cited over 700 times for the first paper that I wrote. And trust me, I never wanted to be a researcher, but it just felt very prudent to me to explain about cannabis and how to use it safely and how to dose it. So I've since written books, textbooks with other people, not all on my own. And I've, as you can read here, worked with so many different groups, ministries, governments, different countries. So I'm bragging a little bit, but what I mean is I've done a lot of different types of work with cannabis, and I'm very passionate about advocating for patients because I do feel like cannabis is very misunderstood and there's still a stigma and a lot of misinformation. And so I had to make a hard decision to change my career, pivot my cannabis career in the early days. And I started working in the area of harm. And what I mean by that is showing if cannabis is harmful or not harmful, or if it is, how we can work with it. So I'm not just a raw, everybody should take cannabis kind of physician. I very much look a lot at pharmacovigilance. So that's studying safety of drugs in particular. And I'm very interested in weighing the risks and benefits and the side effects. So I want you all to hear that because it isn't for everyone. And we need to make sure patients are informed. And it's hard to do this in the medical system when there isn't always enough time to spend with patients. So I do work at Greenleaf Medical Clinic, and that's where we have a staff of lots of counselors and specialists where we can spend time and we can help patients get affordable, but also access to cannabis through the licensed producers. I'm laughing. I put this here because a patient told me that I won this award. I didn't even know that I won this. So apparently I was medical practitioner professional of the year for this conference. And I've done a lot of different pieces in media. I've done different things relating to psychosis and a lot of the myths that we hear. So if you go to my website, you can see any of the other pieces that I've written. So let's dig in. So we're going to start with something called the endocannabinoid system. So I'm not sure if everyone's familiar, so I'll make sure we start right at the beginning. So some key points before I dive into the endocannabinoid system. I want to say that cannabis is used for symptom management. It doesn't have evidence in the same way the different pharmaceutical medications have, where they have indications and they have like DIN numbers and they're sold in pharmacies. It's very complicated. It's a plant, and plants have lots of different components in them. So with cannabis, I talk a lot about symptom management. And also, just to remind the audience that this is for people who typically have tried other measures, they've tried other medications, and cannabis has not, the other medications haven't worked, and that cannabis has been a consideration because they're still looking for treatment response. Also, it's important to know that there's no cure. Like you'll see some of these pictures I have on the slide where, this person was cured of their cancer, and I think that's very dangerous to speak in that way, because everybody's different. Everybody has different types of cancers. It can be spontaneous remission. So I don't use that word when I talk about cannabis. And it's really here to help patients and to kind of find its role if it is for them. And we always continue cannabis in addition to other medications initially, and then we may decide to reduce other medications afterwards. So it's not like you have to stop everything you're using and then you try cannabis. We like to do combination approach, so using it as an adjuvant or an adjunct. So let's talk about the endocannabinoid system. So here you can see in this diagram, there's different kinds of cannabinoid receptors. There's the CB1 receptor and the CB2 receptor. And I know they're very similarly colored on this diagram, but the CB2 receptors are located largely in the areas of the immune system. So a lot of times that might be the bone marrow, the spleen, those sorts of areas. And the CB1 receptors are largely in the central nervous system, but you can see them in some other tissues as well in this diagram. And then there's areas where they're in combination. So important for everyone to know that we all have these receptors in our body. And even if we don't have a condition, like even if without us having diabetes or a diagnosis, we still have this system, and it's still it plays a role in our every single day life in so many areas and so many different functions. It helps us to sleep. It helps us to manage our anxiety, our stress. So it's very important to know that it's there regardless. There's actually some new evidence, I didn't put it in this presentation, but some new evidence to show that people with certain conditions like migraines, irritable bowel syndrome, fibromyalgia, and PTSD, that there's actually evidence suggesting, it's early evidence, scientific kind of more in the area of animal studies, but suggesting that these conditions may have problems within the endocannabinoid system. So that may be part of what's happening in those conditions. So talking a little bit about the cannabis flower, you may hear me call it flower, bud. There's different ways that we describe it. So in the middle of the screen, you're going to see the cannabis flower. The flower is this tight bud, which it grows. And in the picture, you can see here the trichomes, which are these fluid-filled little sacs, which are at the very end of a stalk, which looks like a little mushroom. And within that fluid-filled sac, you're going to find terpenes. Terpenes are what gives the cannabis plant its smell. So some people may smell cannabis and say, I smell lemon, or I smell a pine tree, or I smell lavender. And so that might be linalool, pinene, or limonene. And so the names of these terpenes also we think have medical value in the plant. And actually aromatherapy is very much based on these terpenes. So it's interesting to think of it in that way, that it's also the smell as well as the effect in the body. And then there's cannabinoids. So the main cannabinoids we're going to talk about today are THC and CBD, but there are 150 different cannabinoids in the plant, probably even more. I feel like they discover a new one every other week, and I can't keep track of them. And so really, we think it's the plant together. It's the entourage effect that's giving it the benefit. Yes, you can use each of them separately. You can buy products these days with just CBD or just THC. But patients tell us that when the plant is there together, all the cannabinoids, so a full spectrum or a whole plant extract, that together it's better. And that kind of makes sense to me in terms of how nature would have it. But you can definitely grow cannabis in different ways. You can have different varieties, and they could have different concentrations of CBD and THC. So we definitely see different products, which I'll speak to later in that area. So this diagram, I think, does a pretty good job of outlining what CBD can help patients with, what THC can help patients with, and where there's an overlap in the middle. So CBD, for example, can be helpful as an anti-inflammatory medicine, for neuroprotection, for seizures, as an antipsychotic. I'm not saying that this is, definitely being used in that capacity, but we're seeing in studies and evidence that there is potential for that role to be there. For THC, we're seeing it used in spasms. We're seeing it used for appetite, for sleep, for here I actually have psychoactivity and impairing, and those aren't actually why people are using it. Those are actually potential things we need to be mindful of in terms of side effects. So THC is where we might find some issues with driving and safety sensitive occupations. So I wanted to put that on that side so that people were aware that CBD isn't the same concern in those areas. And I'll actually speak a bit more about that later. So let's talk a little bit about using cannabis for medical purposes, because there are people that are using cannabis for recreational purpose. And so quite honestly, I do believe that cannabis is safer than alcohol. And so I can see why people would use it over alcohol for recreational purposes. And then there are people who use cannabis from the recreational market. That means they buy it in the dispensaries or the adult use market, but they're actually trying to use it medically, and they're doing it on their own. And so it may be because they don't have a supportive physician, and they just don't have the means to get that sort of support. So here I'm talking about using it as a medicine and how we use it in our clinic. So this slide actually touches on what I just mentioned in terms of alcohol and other medicines you can see on this slide. Opioids I have listed here, anti-inflammatories or NSAIDs, and acetaminophen, also called Tylenol. What I've done here is I've outlined what's called the therapeutic index. So this is a little bit of my pharmacy background geeking out here. So therapeutic index is how much you need to give a benefit of the medicine, but how much that could possibly cause harm. And so the more narrow your range, the more unsafe it is, basically. So for heroin, it's 1 to 5. Opioids here, you'll see 1 to 70. Alcohol is 1 to 10. So that's a really narrow range. So it does have a lot of morbidity and mortality associated with it. And you can see I've written some numbers, and I apologize, they're out of date. Of course, you can see by the years of the references there. But for example, Tylenol, there's at least 4,500 admissions to hospital per year related to Tylenol use. And that might not even be an intentional overdose. For anti-inflammatories, there's over 103,000 hospital admissions per year in the US. And that's probably largely related to ulcers, so GI bleeds, and renal failure as well, and usually in the elderly, but still you can see it's pretty significant. And anti-inflammatories such as Advil are available over the counter, so very easy to access, and it makes sense, that the numbers are that high because of that reason. And then for alcohol, 1 in 10 is what I mentioned as a therapeutic index. And opioids I've listed, and then cannabis, so which we're talking about today, so 1 to 1,000. So that means it's very forgiving. I'm not saying it's perfect. I'm not saying people don't have car accidents or people end up in the emergency room, because it does happen. Sometimes it's intentional and sometimes it's not intentional. But you can see the LD50, so the lethal dose So there has been no established dose so far in the research to show how much cannabis you need to ingest to cause death. So there's one, approximate that I found in one reference that said you would have to inhale over 1,500 pounds of flower in a 15-minute period. I think they did this in some rat study they were trying to do. So anyways, impossible. So let's move on to some of the summary of evidence. There is so much evidence growing every day in cannabis. I'm highlighting the main areas here that are notable. It doesn't mean that there aren't more. And I always tell patients that a lack of evidence does not mean a lack of efficacy. So just because somebody hasn't studied it doesn't mean it doesn't work. I'm not saying it doesn't mean it's indicated, but I've had patients come to me when I used to work at the CCDP and say, I take this alpha lipoic supplement and it really helps my pain. But there's no study that says, it treats this kind of pain. And so it's really important for patients to check with themselves, and you are your own best test. So an N of 1 study, you try something and then you can stop it and you can see how that works. And that goes for any medication. In particular, I'm a big fan of drug holidays and of drug rotations, and you can really see then how much that's helping or not. So here, let's talk about the moderate substantial quality of evidence. And so the best evidence in cannabis is in the area of chronic pain, neuropathic pain in particular. There's many different types of pain, and in adults. So we've got limited studies in children, in pediatrics. Also, chemotherapy-related nausea and vomiting is where there's been a lot of studies. And I extrapolate that evidence to other nausea and vomiting, not necessarily chemotherapy. But I have to say that the evidence was done, the studies were done in chemotherapy specifically. Also, it's been shown in spasticity in MS patients, and also in seizures, epilepsy, and different types of neurological conditions related to like different hereditary forms of seizures. There's limited evidence in these areas. So anxiety disorders, cancers, IBS, ALS, Huntington's, you can read along with me here, but it doesn't mean that it isn't growing and that, this won't change, but just to say that it can be used in many different ways. Here are some of the main symptoms, I would say, that patients report using cannabis from our clinic data that when I've gone through, these have been like the top areas: restless legs, tremors, sleep disturbances, stiffness, nausea, vomiting, spasticity, anxiety, appetite, chronic pain, depression, epilepsy, and fatigue. Oops, sorry, there we go. So who should use THC with caution? I've actually written a paper that I forgot to include here, which quite frankly, I think is much better than this paper here, but that's just me speaking. This is written by the College of Family Physicians back in 2014. I shouldn't be so unfiltered, I apologize. The college wrote this paper 10 years ago, and I think the biggest challenge at that time was we didn't know what we didn't know. So the people, largely, if you open this document, you'll see their addiction specialist, and 10 years ago in particular, very concerned about addiction in cannabis. And also, only 1 or 2 of them practiced medical cannabis from the people that I knew on that panel. There's about 49 authors in that document. And when you don't practice cannabis, I think it's really hard for you to be commenting on it in any meaningful way. And so a lot of their statements are actually being made about THC, not about CBD. And so they didn't distinguish that. And I think that's really important for people to know, is that THC and CBD, different molecules, different doses, different outcomes, different pharmacology. And so these statements that they've made aren't fully accurate in my mind. So I was then invited to help them with their revised edition, and they still didn't really listen to any of my statements, despite the 20 hours I must have put in on that document. But anyways, that was all I can do. So here we go. That was just a little bit of a gossip there, and I'm not actually staying on topic. So here you can see the people that need to be careful with cannabis are people who are younger in age, under 25, I really don't think 25, like that age is pulled out of nowhere. I've gone back and looked at it. It has to do with neuroplasticity studies and at what age we deem the brain to have developed, whether that's 20, 21, 22, 23, 24. It doesn't, yeah, I don't really think it makes a difference. If they have a personal history of psychosis, yes, let's be very careful for sure with that one. If they have an addiction to cannabis or an addiction to another substance, yes, we should definitely, keep our eyes open for them. This one here, have an active substance use disorder. Cannabis will not kill you and heroin will. So this is just silliness. Have cardiovascular disease. So if they have unstable disease, so that means they just had a heart attack, they're in active heart failure, yes, we should be careful with cannabis for sure. I have lots of patients with stable heart disease on medications, asymptomatic. We use cannabis with them. Have respiratory disease. So when they wrote this, they didn't tell people this, but what they meant was the studies, if you read all the little footnotes that they used, they were looking at inhaled smoked cannabis. But nowadays we have oils, we have teas, we have things we can swallow. So not the same concern. We have vaporizers. And if you're pregnant or breastfeeding, we're always very careful with that because, we don't have enough evidence. Potential drug interactions. I do have a list of specific interactions. I wrote a whole paper on that as well, with a few of my expert pharmacist friends across Canada. And it doesn't make sense for this audience in this moment to go through every single drug, but I just want to give you some general baskets, if you will. So these are the areas to be considered when we're talking about a drug interaction with cannabis. So cannabinoid levels, so in particular CBD levels, can be increased by other medications. Cannabinoids can affect the level of other drugs. Inhaled cannabis can increase the clearance of some drugs. Very interesting. There can be an additive effect. So this is called pharmacodynamic interaction, not a pharmacokinetic. Pharmacodynamic means that if you're taking a sedating medication and you take a sleepy THC like an indica, it can give you extra sedation. And there are potential red flag interactions. So there are some. In particular, having a very significant reaction is very unlikely. Really, the only one that comes to mind is clobazam, which is an anti-seizure medication used in very severe treatment-resistant seizures, usually as like a final, well, not as a final agent, but when there's like probably 4 other drugs in the mix. So trust me, the valproic acid and the phenytoin and others are definitely causing problems as well. It's not just the cannabis that's causing an issue there. And, you can always talk to a healthcare provider about this. Pharmacists are becoming much more knowledgeable about this. There's some mandatory training through some of the pharmacy colleges in different provinces, which is really great to see. And now I'll move into the treatment plan. So at Greenleaf, this is something I think that we do very well, is how we customize our treatment plans. So there are a lot of physicians that practice cannabis, and it's not necessarily their fault, but they don't have the same amount of time to spend with patients. And as a result, they'll frequently sign a patient an authorization, but they won't give them direction necessarily on what to take and how to take it. So let's go through these steps. So step 1, the first thing I would ask a patient is, what kind of symptom do you have? Is it an acute symptom or an intermittent symptom? So for example, migraines would be, it comes on acutely and it doesn't happen necessarily every day. Nausea, some people with nausea, depending on if it's anticipatory nausea or nausea with food, it comes on at very discrete times. And so for those patients, inhaling cannabis may make a lot of sense because we want it to work quickly and it doesn't necessarily happen every day. People with chronic or persistent symptoms, ingestion is by far and away the best way to go. And so when you swallow cannabis, and I'll talk about the different formats, you metabolize THC to its active metabolite, 11-hydroxy-THC, and that has a longer half-life. So that lasts about 4 to 6 hours in the body. So think of it as your long-acting versus your short-acting options. And so many people use one or the other or both. For pain, for example, both might be a great combination. The next step is looking at the physiology. So what's going on for a patient? Do they have an inflammatory condition? Do they have inflammation? If so, CBD is really good for that. So we may first start with CBD. Do they have a neurological condition? If so, a lot of times THC can be more helpful, but a lot of times we use the two together. And then exceptions to my neurological statement there, if it's a child, I'm probably not going to start with THC right away. If it's a seizure disorder, also probably not. And then bipolar psychosis, I'm probably going to start with CBD as well, first line. So number 3 is, when do the symptoms occur? Is it in the day or the night? So you think about going to the pharmacy, cough and cold products. You can buy a box that has a daytime and an evening, like different blister packs. And so for the daytime, THC may be a really, for the daytime, CBD may be a really great place to start. And then I find sometimes patients don't even need anything necessarily for sleep, because if their pain is better at night, during the daytime with that, they find that they sleep better. And I've also seen vice versa. I've seen patients use THC for sleep, and then because they're sleeping so well, their daytime pain is less. So it's really interesting, and it's very much an individual, process. And that's why we definitely spend a lot of time asking patients about the nature of their symptoms. We ask a lot of questions, and it can be annoying. So I apologize for that. And then other medications. So we add cannabis to other prescriptions before we do a taper or a rotation. But it always fascinates me that some patients, well, many patients, when they're on an opioid and they start cannabis, I'll say to them, please don't come off your opioid quickly. I don't want you to have any unwanted side effects, because a lot of times people have had trouble coming off opioids. And then many of them, when I see them, like, I don't want to say all of the opioids are gone, but certainly like all the PRNs are gone, and they've actually dropped the long-acting doses, and they'll tell me, I just don't need it. I just don't need to take as much, or I feel too drowsy, like the cannabis is working and the opioids are making me drowsier and I want to cut back on them. So that's always really exciting for us to see, because we know that opioids have a lot of other complications that they can contribute to. Opioids can give constipation, they can give us anxiety, they can affect our mood. And overdose and all those respiratory issues as well. So let's talk a little bit about adverse events. So I've divided them up in these different boxes to make it a little bit easier for the audience to read. So the rare conditions, I'll start with those first, because those are the ones that you might hear about in the news that seem very concerning. So cannabis hyperemesis syndrome. So that's something that the emergency rooms would see more than any other department, because that's where they present. So if you use cannabis, it's really interesting. It doesn't matter if it's for a short or long period, there's a genetic mutation. And when you have it, it seems like you're going to be potentially at risk. But people don't usually know that until they try cannabis first. And so, yeah, it's really fascinating. There's a lot of research my colleagues are involved in, looking into different forms of tests that patients could take to see if they have that genetic issue. Also, you'll probably hear about psychosis or schizophrenia, or car accidents. So that can be impairment, which could relate to discoordination, ataxia. Orthostatic hypotension is low blood pressure. And some of you in this audience may already have low blood pressure to start with. So we would be sure to start with a very low dose in that case. So we're careful with knowing sensitivities. A lot of patients with central sensitivity syndrome or CFS or Lyme and all of these conditions, fibromyalgia, they're very sensitive to medications. And so as a pharmacist, I would always at CCDP start them on very low doses. And so the same goes here for cannabis. So we know that. In terms of common acute adverse events, just think about anything that works on the brain, like an antidepressant or an opioid, can cause similar things that you'll read in this list. This isn't special to cannabis. So here, THC can make people dizzy. It can cause anxiety. It can cause dry mouth. It can also have some cognitive effects, potentially. And all of these acute adverse events are dose dependent. So a low dose, we don't see these. I see very few of these, actually. Higher doses, yes. I have definitely seen people complain of dizziness or drowsiness if they've started at too high of a dose. But I'm really glad that there are some global guidelines on how to dose medical cannabis. And myself and some of my colleagues have been involved, and the doses in those guidelines are good. We've erred on the side of caution, and people are getting the memo that we need to start at lower doses. And I think that's the way we're going to avoid these or reduce these common side effects. And then the last ones are route specific. So really interesting that some patients have diarrhea, and it's frequently connected to the oil that the cannabis is in. So it's the oral preparations we see this in. Inhaled, we don't see diarrhea with inhaled, which is why we know it likely has to do with the carrier oil. And a lot of times it's the MCT carrier oils. And it's a lot of times in people with sensitivities to coconut oil, and also IBS potentially. We've seen people with severe IBS that this can potentially be an issue. But don't worry, there's different preparations that have hemp seeds, hemp seed oil, grapeseed oil, olive oil. So there's lots of other options. And then route specific is cough and bronchitis, and that's when people smoke cannabis. We don't see that necessarily. We don't see that with vaporizers unless they use a very, very high setting where it's burning the plant, like it's so hot. But vaporization overall, we don't see those same symptoms. Driving considerations. So very important to know that cannabis can cause, THC can cause impairment. And so there are some numbers in terms of what's recommended. So we should wait 4 hours after inhaling, or 6 hours after ingesting something by mouth, or 8 hours if you were euphoric. And so those numbers are just loosely there. Honestly, where this evidence comes from is largely around people who don't use cannabis every day. It's for people who use it intermittently, and they have a much greater effect than somebody who uses this every day. I have patients that tell me, I actually am a better driver on cannabis because my pain is controlled, my anxiety is better, my PTSD is better, and I'm actually safer. And I truly believe that. And likewise, there's medications that people drive with, like benzodiazepine, Gravol, Benadryl, sleeping pills that can cause a hangover effect and can cause issues with driving. And it drives me crazy that we don't talk about these issues, but we pick on cannabis for these numbers that we've outlined here. So I think we need to treat all medicines the same. So I'm just, putting a little plug there. And also be mindful, THC with alcohol is definitely, more of that kind of synergistic or that compounded effect that I talked about earlier. And then, yes, please also, if you're using other medications that can cause impairment, as I've already said, using cannabis with it, either do that on a weekend when you first start, use the THC at bedtime, not during the daytime, or make sure you don't have to drive the car or do something right away in that case. I'm going to touch a little bit on cost. I'm going to list the products here just for the ease of the audience. I wanted to keep it really clear and use pictures here and keep the words a little more concise. But you can see here the difference between these different routes of administration. The first column we have is inhalation, in particular with a vaporizer. I don't, choose one vaporizer over another for patients, but this is one that patients really like. They find it only has one button and they like pushing one button. And it also has a really good battery and I have another whole talk on just vaporization. And I've actually recently written 2 manuscripts on vaporization for public health. So we have a lot more to talk about. So I'm trying to keep it really short here in the interest of time. So with vaporization, it takes seconds to minutes to work, but it only lasts usually up to 4 hours. But I've had patients say even only up to 2 or 3 hours. Ingestion, you can see here that it can take 30 minutes to 2 hours to work. And so everybody's different and they're unique. And people will say, oh, well, if I eat it with fat, if I have it with, food containing fat, that it will absorb quicker. And I could see that because cannabis, these molecules are lipophilic. And then it can last for up to 8 hours. And so that's, again, really good for patients, but also depends on what they're doing with their day-to-day lifestyle. And so we're good at trying to put together the right combination of agents to match a patient's daily needs. Topicals are really popular among patients because sometimes they'll have pain in one area, but they don't want to take something by mouth. They need to go pick up their son at, at school, and they want to put on a little bit of topical with THC, and then they can drive the car, and then they come back home, and then they can take their THC orally afterwards. Suppositories, honestly, it's way more new, this area, and I just don't have enough feedback on them to comment on them. Also, the absorption is very different. And the salts I think they're hemisuccinate salts that are bound with the THC molecule. And the rectum is complicated anyways because the blood supply is different in different areas of the rectum. So, if you can get a lot greater absorption depending on where you insert that. So I don't usually recommend them. There's people who are, really excited about them and they make their own. And it's definitely not a place where we start with patients. Always start low and go slow. And yeah, just one more comment about the topical is that it works very quickly, which surprises me. I thought it would be more than 5 to 15 minutes, but patients do find it to be that quick. And then here, these are some different oral products. There's oils, which are the first column. I really like them because the syringe allows us to dose with such accuracy and such small increments. Whereas the soft gels are fixed doses, as you can see, and it's harder to work with. With CBD, it's not as big a deal, but with THC, I definitely prefer to use the syringe option first. The dissolvable strips at the very end, think of them as those little like Listerine strips that you put on your tongue. So patients do really like them. Sometimes for different reasons, if they can't swallow or they've got taste or sensitivities, it's an option, but it's more expensive, as you can see here. And again, the accuracies is not quite the same, but it's definitely easier to change the doses when compared to the soft gels and the dissolvable strips. And then there's sprays, which are newer, and patients do report them to work quite well as well. I think because they spray them under the tongue, and then they're absorbed in the buccal mucosa, and then they're swallowed in the saliva, that what patients tend to report is that they work a bit faster than the oils, but they last as long as the oils, which is nice. And so I've highlighted in the chart the cost per milligram so you can see which is the most expensive for CBD and for THC. But really the important numbers are how much is this going to cost me a month? So the first line is a starting or is a low dose, but like sometimes we'll start even lower than that. So that's probably the lower end of what you could spend. And then if you're taking a bit more than that, that's what the second line is in all of those columns. So here we can see bedtime, we use very small doses of THC. So it could be about $7.50 a month, which is really great. So with people who are limited in their income, we always ask that question and we start with the cheapest dosing regimen, which is usually THC at bedtime. CBD is more expensive, so we might reserve that one. Here's some flower numbers. So you can see it's quite a range there. And the only issue is they come in a minimum size quantity. You can sometimes get 3.5 grams, but a lot of times it's 5 or 10 grams. So it's not like just $4.50. Like you have to pay, for a whole supply. And then here I've made a comparison. You can see the ones on the top we've already talked about, but the adult consumer market, just to show you in terms of comparisons for cost. So the teas, sodas, shots, they've got ginger, turmeric shots. They've got all kinds of shots out there. Powders, which are dissolvable in any drink that you want, chocolates, baked goods, and chews. I really don't like the sweets. I think that, and the sodas, I just think we're starting to have that this is going to be an issue for cavities and diabetes. So I tend to, if a patient was going to go this route, to say, the teas or the shots or something like that. Gummy bears is another one that's under the chews that people do like, and they can cut the gummy bears. So sometimes that's an option. So for the audience, are you considering using medical cannabis, or maybe you already are using it? I just wanted to share with you the referral process to our clinic because some people aren't really clear on how that works. So we typically ask for a referral from your doctor to see us in clinic. If you can't get a referral, you don't have a doctor, we can work with you still. We have another way that we partner, and we have a family physician help us with that. It doesn't mean that doctor's going to be your treating physician. It just means they're going to see if you're appropriate. And then you're going to be referred, you're going to fill in your forms on the website, and our wait time is around 2 weeks, give or take. It's pretty quick. And then you'll see a physician, and then you will be emailed a copy of a treatment plan. Like I showed you earlier, it'll be customized to you. And then we will register you with the company you're going to buy your products from. And we do that. Like, we don't give you a piece of paper to take to a dispensary. We sign you in through the legal medical stream, and then you order online. They take various forms of payments, and they're pretty easy to work with. They've been doing this for a while. And then the last one is you order your product and it will be directly shipped to your door. So it can take, the quickest I've seen it is 48 hours. It can take to show up, but it comes in registered mail these days, and it's quite quick. The other thing I was going to say, there's something else about the process. Oh yes, we have our groups, our patient groups that we like to do how Dr. Arsenault was suggesting. We have big groups where patients get to learn from one another, and we teach them all at the same time about cannabis. And the reason we do that is because it's really good for them to understand all of what we talked about today before they see the doctor. So in that case, they're able to ask the right questions, and we can use the time in a more efficient way, because the physicians can't go through all these little details like what we're doing today. And then if you'd like to get information on us, if you're interested in a referral and being seen by one of our physicians, you can see here there's our website, and we have a learning center with a lot of resources if you want to learn more about cannabis. And you can also attend our groups, and you don't have to start cannabis right away. There's no you have to do this if you do this. But I do want to mention that we have a membership fee. It is a sliding scale. It's based on the number on your notice of assessment. So it's based on how much money you do or don't make. So it's not based on how much the whole household makes. And so we like to make sure that we can offer something to everyone, and enough to say that cannabis does cost money. So if you can't afford the membership and the support from the team here, there's a good chance you can't afford cannabis. So I just want to put it there. I'm not trying to discriminate against, because we really do want to help everyone. And we're really good at finding a cheap alternative, but just to say, there is a cost involved. And then just a couple more resources I want to mention. So on my website, which is my first name, last name, so DR, and then CarolineMacCallum.com. You can sign up for my newsletter. And so I send out different evidence or publications on cannabis that I've been working on. And it's a good way to keep up on the evidence. And then you can also see some social media information for me here. And then also on my website, if you go to the cannabis safety tab, you'll see this slide here, which has all the different kind of categories where I publish papers. So all of my papers, I have paid sometimes out of my own money to publish these open access. So what that means is you don't have to pay to download them from the journals. So a lot of times people have grants that cover this, but I'm not actually a formal academic, and I don't work with a department where I get funds towards this. But a lot of these papers have been really important, and I really wanted to make sure that they were available to everyone. And quite frankly, I write the papers to be written by the patient. Like, my goal is, I personally have ADHD, and if I can't quickly read my own paper, like, I'm not publishing it, because it's just too complicated. And, I basically have brain fog myself at times. And so you'll see a lot of charts, infographics, pictorial, diagram representation in them. And so it should be quite easy to read, I promise. I mean, some of it's going to be fancy, but you'll be able to get the gist for sure. And so at that, I'm finished, and it's a bit early, so hopefully this means we can take some extra questions then. So do I stop sharing on my end?
No, you don't need to stop sharing. You just need to bring up the
Okay.
Q&A for yourself, and then you'll be able to, patients
Oh,
cannot see the question, so you'll need to read the questions before you answer them.
okay. So for me to see the question, thank you for reminding me. I'm gonna have to stop sharing my screen and oh, now it's on my screen. That's why I couldn't see it, because my slide deck was making this not. Oh, here we go. Wow, this is fancy. I have a piece of paper here. So if it looks like I'm distracted, it's because when I'm thinking, I like to write to myself, and people ask good questions, so it's always nice to write them down. So I'm going to go in order of these questions. I think that probably makes the most sense. So do you guys, oh, are these, did you say they can't see them, Dr. Snow, or they can see them? Because one of them sounds like it's almost a question.
Yeah, they cannot see them.
They cannot see them. Okay. Because it says here, do you want this to be a public conversation? Oh, well, this is public. Oh, this is just maybe questions before we got started. Let me just scan through them. And today is being recorded. Somebody was asking if it was going to be available afterwards, and it is. Just scanning through these. It says I can either answer live or type in the answer. I'm answering it live. Does that mean I should click that I answered it live, or?
Yeah, just answer it out loud, because otherwise, if you type it in, it'll only go to the person who.
Oh,
Yeah.
okay. Okay, perfect. So I'm going to just say, yes, so I've already answered that. That is being recorded. Perfect. The next person has asked, I would like to use both THC and other constitutes, perhaps at nighttime. Will that have any possible benefit from the CBD? Or is there any other way I do that? So this is a great question, and there's a few comments to answer. The first thing is, in brackets after THC, it said concentrates. And so just to remind everyone, concentrates, I didn't get into details in this lecture because this was a general overview, but I have a whole webinar on edibles, concentrates, and other products available in the adult use market. And that definitely deserves its own time because it's complicated. But what I do want to say briefly for this audience about concentrates are concentrated. They can be up to 90% THC, very, very concentrated. I'm not a fan of concentrates personally. I don't consider them to necessarily be a medical product. I consider oils that you swallow, and the oils, there's rules and regulations up into the maximum concentrations. And so in my mind, they're safer. So oils for oral and vaporization, those are the two main medical routes that I'll talk about, as you heard. Also about concentrates is it's really hard to dose them. Like the way they're available, people frequently take too much and then they regret that. And I'm just trying to see what else here. And is there any other way I can do that? The other piece I want to mention is some people use CBD for sleep, but I find by far and away THC is better than CBD for sleep, for sure. Now, if you have a lot of inflammation and you think part of the reason why you're not sleeping is because of the inflammation, then by all means, like CBD could be a great option for bedtime as well. But I do find for inducing sleep, THC to be the better option there. Yeah, I think I've answered that question. Next question. Yes, this is being recorded and there are slides that we're going to distribute. I'm just reading this one's a little bit of a long one. I just need to make sure I got my head around it. So interesting here, question about microdoses or microdosing of cannabis. And that makes me so happy because that's personally like what I'm so jazzed about. I personally started using cannabis in the past couple of years, and I would say that I microdose. I use very, very small amounts because I'm very sensitive to it. But also, I think that when used correctly, when you find the right kind of cannabis, you don't need very much. And so when people use a lot of cannabis, I think it's because it's probably not the right strain. And so we didn't get into that today. I have a talk on that as well about how to do a strain rotation, when to do a strain rotation, because sometimes a strain could work for a patient. And then within 3 months, they say, oh, it's not working quite as well. And so there's something about it where they get used to it. And then we rotate it to a different one. And then when we rotate back to it, it actually they then are not tolerant to it. So it's interesting how we do these rotations. But the question here in particular about microdose is about a closely medical supervised way in a hospital. And honestly, it really isn't necessary. We can start at such low doses. I'm treating 90-year-olds, 95-year-olds, people who are very, I do some work with pediatrics children. We're really good at dosing low. And like I pointed out, that syringe will allow us to go really, really, really tiny. So 1 drop at time. So that's I don't think that should be an issue. A hospital setting would not be required here. And then I'm also seeing there's a specific piece to this about this person has a specific condition on top of their CFS. I just want to read about it. Interesting. So they had a flaring of symptoms like POTS and hypertensive episodes. So sounds, and this was after COVID. So definitely we've seen lots of interesting things that present in cardiac conditions such as this. And so cannabis triggered this. So my guess is that was THC for sure, triggering that tachycardia and hypertensive episode. And so I would say starting with the CBD product would be the way to go. A really, really low THC and a high CBD. And so how we would do that is probably a hemp-based CBD product. So I didn't get in the difference between hemp-based products and CBD from flower. And so CBD from a hemp has less than 0.3% THC by definition. We don't find it works quite as well as normal CBD from the flower, but it's definitely a workaround if we wanted to be super, super careful of the THC content. So that would be my answer for that question. I'm just reading to make sure it's quite a long question. Yeah, I'm pretty sure I answered that fully. I want to make sure it's applicable to everyone. So I'm happy to make little comments. Some things are a little bit specific, but I want to see if we can get information to everyone here with these questions. So we can, I always find patients, they learn from each other's questions. Sometimes they think, I didn't even think to ask that question, but that applies so much to me. And that's like my takeaway was that one question. So I love it. So here, wondering about pain relief with only CBD and no THC. There's two parts of this question. Also, young, so 20-ish years of age, and family history of psychosis. Also, other conditions in the background like ED and CFS. So I did mention psychosis, being very careful of THC. Because there have been associations between the two that they certainly have worsened. Again, dose dependent. And with young people, we're just always want to be mindful that, you know, the younger you start something, there's a greater risk that you could develop an addiction to it just in general. It doesn't mean it has to happen. And obviously it changes depending on the substance. So, but 21 is, I'm not worried about a 21-year-old. And then, I mean, in the sense of the cannabis sense, I'm not worried about that. And then what are you about pain relief? So CBD only, yeah, I do think it's worth a shot for sure to do that. But I also want to remind everyone, and I sometimes try not to get in the weeds, pardon the pun, because there's so many angles I can go. I can speak for hours on this. All CBD products have a little bit of THC. And the reason is the plant can't grow without it. It's just how it goes. And so what's really important is to find the CBD with the lowest amount of THC possible. And so, as I just mentioned in the other question that I answered, a hemp-based CBD product would have a lower amount of THC than a flower. For example, a flower usually has 1 milligram for every 20 milligrams of CBD, whereas you might be able to find 100 milligrams of CBD for 1 milligram of THC in a hemp product. But that to say, when you start low and go slow, which is my mantra for everything, and cannabis as very, very most importantly, we find that patients can tolerate a little bit of THC, even though we say, oh, be careful with this condition or that condition, but a lot of times they can tolerate it. And there's been studies showing using CBD in particular with psychosis that it can actually help to stabilize it. So having a bit of the CBD with the THC, I think, is definitely the way to go. And if I'm being totally honest, when patients tell me that CBD works for their condition, they say, oh, I don't need any THC. The CBD works for me. It's the little bit of THC in the background that's probably working that they don't even know is there because it's called CBD dominant. But the reason when patients get up to higher doses of CBD, 100 milligrams, 200 milligrams, 300 milligrams, it's because they need the 2, the 3, the 4, the 5 milligrams of THC that accompanies that ratio in that bottle. And so frequently I'll tell patients, buy a separate bottle of THC and a separate bottle of CBD, because then you can titrate it and you don't need to keep jacking your dose of CBD, and you'll save money then that way. So that's a really interesting and important point to make. And yeah, I answered that one. I'm just reading. Yeah, so mental health and teenagers and developing mental health when they were smoking cannabis. And so definitely that's THC related, usually high doses. Frequently, if we don't know what they're smoking, it could be these concentrates that are like keef, shatter, dabs. All of these things are very dangerous, very high potency. So it can definitely be connected. And so is there risk of, is it reversible or non-reversible? So I actually wrote, I did write a book chapter on this one. I don't know if that's on my website, but we usually see that it's reversible in terms of some of the anxiety features. But the jury's kind of out, because I don't want to say that this is always true, but we have seen over time that it can be reversible. But with the psychosis and the bipolar and those other areas, it's really hard to say. Is CBN comparable? So great question about CBN. So CBN is another cannabinoid. So as I mentioned, there's CBG, CBV, CBDA, THCA. There's all these different molecules, and I have a complicated diagram which shows you how they metabolize some of them from one to another. And in the plant, you typically have that many in any given plant, but they'll be dominant in a couple of them. CBN is unique in that it is the degradation product. So if you have old cannabis, it's funny. I'll tell a funny story. My friend gave me this cannabis, and I don't like. This is like a long time ago, and I wasn't really using much cannabis. So I was like, I don't want to buy any because I'm not using it really. So he gave it to me, and I said, oh my gosh, this works so amazing. And so I finished it, and I was like, okay, I want to get some more. And he was like, that was 3 years old. And I'm like, what? You gave me 3-year-old cannabis? But what it was the CBN was really high, because probably the CBD and the THC rather had degraded to CBN. And so I think that's why I thought it was helpful for sleep. So for sedation. So that's how CBN is used for sedation. And it is present to a certain concentration in the plant, but a lot of times what you'll see when you see an oil product, you'll see it as a milligram of CBN, and they've probably reconstituted. They've added like, you know, a squirt of CBD, a squirt of THC, a squirt of CBN, they've had to reconstitute it because it can be hard to get the right milligrams for CBN and some of these other cannabinoids that are usually really low in concentration in the plant. I just want to mention that. But here, another part of the question is it normal to get headaches from a THC CBN tincture? And that's also a great question. And I'm sharing all kinds of personal anecdotes today. I tried a gummy and I consistently tried it for a number of days in a row. And I got headaches every time I took that gummy. And I never got that. Like, I very rarely have had headaches with cannabis usually. So I know one of them had CBN in it. So interesting. It's a good question. I'm not sure if that's why. When I went back to the dispensary and talked to the guys at the desk, they told me that they wonder if the dyes, so the coloring in the gummies, can also be affecting, like giving people side effects. So some people are color sensitive, and I know in this audience there's definitely people who have sensitivities to colors and additives to different types of pills. So I want to mention, we didn't talk about in the question what source this was coming from, but definitely, I think they said the blue and the red like had more side effects reported to them. So maybe that's where the headaches. And THC, I wouldn't say people get headaches. Like, some people do, and they get headaches with THC. They probably get it with every form of THC. But then the question would be, try CBD. And then if the headache goes away, then maybe you just need a bit more CBD there with only a tiny bit of THC. And then yes, CBN, I don't think it always causes headaches, but I had that experience. And so I just want to mention that, yeah, it could happen. And a lot of people, when they're sensitive, they're just more prone. Like, that might be this, headaches could be your thing that you get with most things that you try. Like, I know if I try another medication, I can get a headache pretty easily as well. I'm curious about the effectiveness of cannabis in managing rheumatoid arthritis. So yes, I have seen a lot of patients with rheumatoid arthritis, or, you know, in the realm of, you know, scleroderma and other related conditions that are autoimmune in nature. And I have had patients find it can help some of the swelling in their joints. That would be largely CBD. The THC can be helpful in their pain. So in their pain, also sometimes with chronic diseases, as many of us know, there can also be a mood component, for sure. And when you've got loss of function and loss of our activity of daily living, that can be hard. And that cannabis, maybe it's also boosting the mood. And then by boosting the mood, you know, the pain is like, things are better. The glass is half full, maybe not half empty. And also, I think when patients start sleeping, so THC helps with sleep. So if you're sleeping better, your ability to tolerate pain in the daytime is better, just because. And also, when you're sleeping better, your anxiety is better. And then when your anxiety is better, well, for me, I don't catastrophize my symptoms as much as I do if I haven't slept. Like, sometimes I feel like I'm just like, wow, like, this is so painful. And then other times I have a different tolerance for it. And I'm sure there's other people in the audience that agree with that. And actually, something I've noticed, and I don't know if others have noticed this, is even with the time of your cycle, like the estrogen and progesterone, it's crazy. I have a good friend who started hormone replacement, and her pain changed very significantly. So it's really interesting, but not everybody is the same way. So I don't want to get too off topic there, but so there's all kinds of factors. So I'm not talking specific in this question to rheumatoid arthritis, even though that was what the question was asked about. Well, I did specifically talk about it, I guess, but I'm talking about other forms of pain extrapolating from this question. So people with anxiety, people with sleep, people with mood, and pain. So I hope that that's helpful for others. Hives. So this person has hives with medication. I also sometimes get hives. They have an EpiPen. Cannabis can help my fibromyalgia, or cannabis does help my fibromyalgia, sleep, and anxiety. And I found that other products are very drying to my mouth. Is there any way around this? So don't fully have, like, I'm extrapolating from this question because I think I'm missing some pieces here for me to be able to fully answer, but I'll just say what I can about it. The other products, I'm not sure if that's other cannabis products or if that's something else. So it could be that THC is where the mouth dryness can come from. So maybe try more CBD and maybe the dry mouth will be less of an issue. And the other thing is, I mean, lozenges, sprays, drinking water, you'll definitely get your daily intake if you've got a dry mouth. You know, those can be other ways to support a dry mouth, but I would say it's dose dependent to how much THC you're taking. That's usually where I see that. Is taking CBD without any THC even useful? Good question. I mentioned that there's already a little bit of THC in with that CBD. So even if you're taking just CBD or you think you are, there's a good chance there's a little bit of THC in there. And again, this is back to that entourage effect. So it depends on what you're treating. If it's inflammation you're treating and you find that when you take that CBD product, it helps you, then by all means, go for it. I don't want to say there's one way or another way, but a lot of patients, when they try CBD and then they increase their dose, and then because our treatment plans will tell you on day 1, do this, on day 2, do this, and then they're increasing their CBD, Once they hit 25 milligrams of CBD, we want to have a conversation, because what it tells us is you probably need THC. Like that's the writing on the wall for us, because we just don't want to waste your money. By that point, we should know. So that's a good question. I think that was nice for me to clarify. Another question about CBN, which we talked about, and then CBG. So question about CBG. So CBG has been used for anxiety, and it's not supposed to be as sedating as CBN. And so that's another option. I have had a few patients use it, but they've been using it in context with CBD and THC products, like it's a combination product. So I haven't heard of just a CBG product. Hope that answers that. Traveling. So I took out the travel slide, but thank you for asking me. It's a little bit complicated. We have information on our website, but it's not that complicated. So don't bring it with you anywhere when you leave the country, full stop. Because even if you're flying to a country that is legal, like for example, I had a patient who was flying, where were they flying to? Mexico, even though it's not fully legal in Mexico, that's controversial. But they had a medical, note or a prescription from a doctor down there that they were going to be able to use it. The problem is they were traveling over US airspace, which is federally illegal despite certain states being legal. So I just tell patients, do not leave the country with it, no matter where you're going, like outside to another country. Within Canada, you can travel to any province with cannabis. And if you have a medical license, you just show like what you're allowed to bring with you. So you're allowed to carry, I think it's 1 month, so 30 days. So if you were given 5 grams a day times 30 days, that's 150 grams worth. I don't think they're really checking, or they might not even know what that even looks like, and the prescription. So I think you're okay as long as you bring like some proof that, you have it medically. But even if not medical, the new regulations, there's personal use that you're allowed to have it. So you can grow 4 to 5 plants on your own without a medical license, and you can travel like with it in your pockets for up to a certain amount. I'm trying to remember what that is. It might be actually 150 grams. I'm not sure. I'll have to get back to you on that. If somebody wants to email me on if they want to know those kind of hard numbers, for travel, I can let them know, but it's also available on our website, so that might be better. I just want to make sure there wasn't other questions. So if you're going to the US, there are lots of dispensaries. You can definitely find products down there. They're not all equal. There's not enough standards in place or checks and balances, unfortunately, just because when you're not federally legal, they can't impose the same regulations, which they do in Canada. So yeah, you don't really know what you're going to get. I wrote a paper on product safety. And so that was my attempt to try to help US patients navigate that. So if you go on my website and you look up that, you'll see what you should look for in a product to make sure that it's safe. And only if a state is legal, of course. If the state is not legal for cannabis, then you should not be buying it there, or traveling from another state. Technically, you shouldn't even drive over the border of that state. And the question says, I wonder if you will be available to do a future medical cannabis series. And yes, I'm happy to do that. I was just talking before we got started with Dr. Arsenault, because I think that there's a lot of people in this audience that would find it helpful. Also here, how is secondhand cannabis smoke comparable to cigarette smoke? That is a great question. So what I can say is, when you smoke anything, it's a combustion process, and you're making carbon monoxide, you're making polyaromatic hydrocarbons, and you're making ammonia, and other toxic things for sure. I'm missing a good few there. Those are the ones I know off the top of my head. And so that's combustion in general. And there's a lot of tar in the cannabis plant. People don't realize that. So there's actually 4 times more tar in cannabis versus tobacco. However, maybe it's the CBD, maybe it's the THC, but when you look at smoking studies with cannabis, it doesn't have major, there were some studies that showed bronchitis, but we don't find lung cancer, like due to cannabis smoking, but we do due to tobacco. So there's definitely something different. So it's probably the anti-inflammatory effects from the plant is what I would imagine. So yeah, I would definitely say I highly discourage smoking cannabis. I usually recommend a vaporizer, and that's why we did a whole presentation on that. And sometimes patients will say, but smoking works better. And what I usually tell them is that when they're smoking, my opinion is that they're getting a drop in their oxygen to carbon monoxide level, carbon dioxide, like they're getting like a head rush is what they're getting from smoking cigarettes, from smoking cannabis. And so that dizziness, I think, is how they equate to it working versus it being the time it actually takes for the THC to get in the bloodstream and circulate around the body, which, is longer than they may think it is. And then a lot of people combine the tobacco with the cannabis. And so that's not good. I wouldn't recommend that. But I don't actually know about the secondhand smoke. I just think smoke is smoke, as far as I'm concerned, is what my answer is going to be for that. But that's a great question. I've never been asked that in my 10 years of talking about cannabis. The last time I took a small dose. Yes, I answered that question. Very similar question to something else that we just talked about. Yes, somebody asking about cannabis hyperemesis syndrome. I just want to make sure. Yes, so just saying it's under study, totally agree, because honestly, hyperemesis or cyclical vomiting, people think it's like other things, like they think it's a GI problem, or, maybe it's psychosomatic or other things. But yeah, definitely can be cannabis related. And some people, it's not even that much. They do think it's largely related to THC, but I've even been on panels with patients who have lived experience with this condition, and they've said that even when they go to take CBD products nowadays, that they can't take them. Like, you would think, oh, it's not THC, but the problem is they're primed, and that little bit of THC that's still in that, product, even though it's much smaller than the CBD, it's enough to trigger the cannabis hyperemesis still. I actually wrote a bit of a book chapter on that one as well, which could be on my website under a side effect. It would be in a side effect chapter. So great point. Oops. It's a little alarm, but we're in the Q&A, so we're good. Somebody asked, if you get sick the day after you smoke cannabis, although it was consumed with alcohol, would the reaction potentially be different if consumed in a different way? Yes, definitely. That's an additive additive effect, 100% sure there. But it's also dose dependent. So if it was a lot of THC, it could still probably, give you an issue even without the alcohol. So please, again, that's start low, go slow. And then somebody asked about sensitivities to grass. So if they have sensitivities to grass, wondering about sensitivities to cannabis. So great question. What I will say about that is I have had patients who have reported swollen lips and a little bit of facial swelling, like maybe 5 patients, not like out of 10,000 that I've seen, but even in our clinic, we've seen over 50,000 or more. It hasn't been something that we've commonly seen. And for sure, there's a lot of people out there with hay fever and allergies. So I'm thinking the two aren't necessarily connected, but they could be connected. So answer would be start low, go slow again. And it may be actually in that case to try an oil, not the bud. So don't vaporize the bud because just the aerosolized nature of it might actually trigger more sensitivity. So I would maybe consider an oil if that was the case. Oh, somebody's asking about, I guess, or making a comment about their son having severe dystonic cerebral palsy, and that they've used cannabis in a G tube. So that's a feeding tube. And that he was so sick, but that the oil is the only thing that's helped him relax his spasms. So they're very grateful. Oh, okay. Staff it lined up to see. I'm not sure exactly the end question, but it sounds like a patient that I've seen. I wonder if I've seen this person. Yes, I've seen young kids with very rare conditions, genetic mutations that there might be like 20 cases in the world where they are very much using cannabis and actually THC. So even though that is counterintuitive to what I've just said, I've had young kids like 5 years younger where I put them on some THC because we've tried CBD and it hasn't worked and they're still having seizures and losing their brain tissue, like the anoxic brain injury. And we've decided, let's try the THC, and it has been helpful. So yes, THC has side effects, but we also have to look at the patient and look at the pros and cons because there's other things to consider, especially if they're in and out of an ICU setting and very sick and having seizures. Oh, somebody's saying that they like that I shared my personal stories and not to worry about that. I'm a Newfoundlander, so it's just hard not to. We just like don't really have a filter, I think. Or maybe that's just me, who knows. Somebody asking about the BC Compassion Club. Yeah, low blood pressure and fainting. With high THC extracts, exactly. I remember when I first started working in cannabis, a patient brought me in a brownie. They were like, here's a brownie for you. And it's like, thank you. I just didn't want to be rude. It was 400 milligrams. 400 milligrams. I didn't get into the dosing here in this talk because it just can get like really too heady, but frequently we'll start dosing at 1 milligram or 2 milligrams of THC or 2.5. It really depends on the increments of the concentration. So let's say 2 milligrams of THC. This brownie was 400 milligrams of THC. Like, that's insane. Of course, people are going to be having problems with that. And that's no longer allowed anymore. That's where the regulations came in, and Health Canada's got maximum dosing. So per unit is 10 milligrams of THC. But still, there's ways that they can get around it, and there still can be issues. Again, issue with cannabis, hyperemesis in these high doses, not surprise at all. We answered that one. Any evidence for people with sensory processing disorder? I'm curious to know more because it's always, so varied for everyone. I use edible oils for restless sleep, for appetite struggles, especially due to sensory processing disorder and pain. I would say what I know, my experience largely in this area is relating to pediatric autism, ADHD. And yes, I would say that there's so many different metrics that I would be checking in with patients. And one of them would be to see, are they eating? And sometimes they're not eating, but we don't always know why they're not eating. But many of them were able to eat and gain weight. And the question was, is it because cannabis was inducing an appetite, or were they more relaxed and not as uptight about the textures and the rigidity that they had around some of that? So it was kind of hard to say. But yeah, overall, I would say that I have seen improvement in that area, but in children. So I can't necessarily make that comment for adults. Thank you for mentioning that, because it's so hard to get into all these anecdotes and different conditions that people use it for, because they do use it for a lot of different things. Here, this is a question around long COVID. Yes, long COVID. I think long COVID is very similar to CFS to me. Like, that's how, like, personally, I treat them both the same, or I would treat them very similarly. I haven't been in touch with Rick in so many years. I would love to hear his comments on that. But I would definitely use CBD in the same way for these symptoms, for sure, to see, providing there's a good reason and they're significant enough and that sort of thing. I don't mean let's give CBD to everybody with long COVID, because, well, I don't know, maybe we should. But yeah, I just want to mention that it makes sense mechanistically. Let's see. And not for pain. Yeah, you don't have to have pain to use cannabis. So definitely CBD can be an anti-inflammatory and can help with inflammation in general. Constipation, interesting, with ingested THC. So I've heard both. I've heard diarrhea, as I've mentioned. Not as much constipation, though, I would have to say. However, I would say that CBD has more of an impact on the gut. So if you've tried ingesting THC, my suggestion would be to add some CBD on with that, or see if there's a combination where you could try more CBD, and if you still have that constipation. And if you still do after the fact, next would be to go to a spray or the dissolvable strips, because I'm curious if you can bypass the gut and if that could be helpful. What is an alternative? Oh, for the diarrhea. So I mentioned that if the diarrhea is there, it's usually related to certain carrier oils. So we could try a different carrier oil for sure. Or we could do the strips, as I just mentioned in the last, or the sprays. Is it true that CBD is slightly more effective if used with THC? I would say yes. This is the entourage effect. Yes, yes, yes. And truthfully, probably all CBD is going to come with a little bit of THC, as I've said before. Tolerance, great question. I didn't really get into tolerance here because that can take some time. I will give you a few bullets on it. I'm also keeping an eye on the clock here. So tolerance is something that occurs when you use a substance for a prolonged period of time repeatedly, so on a daily basis. If you use THC once a week, we don't see tolerance. If you're using it every day, we want you to be tolerant to it, because that means that we can increase the dose where we get you more improvement in your symptoms, and we're trying to fight against not getting those side effects, right? So we want you to slowly work your dose up until you say, oh, it's better, like this is the right dose. And you'll know, because if you go too high, you'll just be getting side effects, and you don't want that. So I rely on tolerance, but I also am very mindful, once people are on a certain dose of THC, we don't like to go too high in our clinic. We actually have maximum prescribing amounts for THC, because I truly believe that if you're using that much, it's probable that you need a different strain, or you need to talk to a doctor, you need a strain rotation, you need a washout. We sometimes wash people out. We use CBD to do that. So we have a lot of complicated treatment regimens at Greenleaf that we use depending on the circumstance. But I also think what this question is getting at is tolerance in general. Like, a lot of times what you can see in the recreational market is people using higher and higher and higher and higher amounts of THC. And this is especially prominent with concentrates, keef, these very high potency. This is in the paper on my website called Product Safety. The potency, shatter dabs, those sorts of things, you'll see that people get really tolerant and they're using massive doses, high risk of having unwanted, issues between impairment to the hyperemesis and many others. Psychosis is another. Somebody said that there was an issue. They came to us, but they weren't able to proceed because they had some issues that they were trying to deal with. Yes, we do need a referral. If it's been longer than a year, we probably should, but if it's every 6 months, we're pretty good with that. So we probably need another one, if that's possible. Asking again about CBN, CBG, which I feel like we've answered quite a bit. What do you think about organic homegrown? So honestly, all the licensed producers in Canada, the criteria is so strict that they have to uphold to through Health Canada. I don't think you have to have organic. Like they're not, I can't say none of them are using pesticides. I know many years ago there was something, were they using pesticides and questioning that? And I mean, it is possible. Like there's always things that they can use that, we don't necessarily know about. But it's pretty strict. In the US, whole different situation. But organic, I mean, if you can afford it, it just can be very expensive. And if it's homegrown, I just want to make sure your seeds are good seeds and that if it's CBD, that it really is CBD, because it's hard to get good CBD and it's hard to grow good CBD. It's a smaller plant and it's a little bit more finicky to grow. But it does make it more affordable. You're right. And growing is not for the faint of heart. It costs a lot of money to grow if you're doing indoor lights. And we have a course at Greenleaf on growing, or we did have one. We haven't done it in a while. So make sure you know what you're getting your hands into before you think it could save you money. But if you get a fungal or you get an infection in your plants, you can lose your plants and things can happen. So that's that. Tolerance, talked about that. Addiction and withdrawal. So I have, quite frankly, never seen addiction in a patient in my clinic to cannabis that we've authorized in all of our years. People have come to me with an addiction that they've done on their own means through other ways, but that has not been an issue for us. I think that if you use medically under 2 grams a day, which is really where I believe most patients should be, this will never be an issue. Using all those concentrated things we talked about, it can be an issue for sure. Are there subsidies? So there's a medication called Nabilone, which is prescription THC, like a synthetic. It's not exactly THC, but that would be covered under a lot of health plans as a prescription drug, but cannabis typically isn't. There are some private insurers that have like a certain amount per year under the health expense account. And so we know which companies have them and which ones don't. And so if you were referred to the clinic, we could help you in that way. One other thing I will say is if you make under, I think the cutoff is like $30,000 or $40,000 a year. Some of the cannabis companies, we have a list of them, they also will give a reduction in like a 20% discount on your cost to help you there. I would love for the government to pick it up, but that might be a while. Can you talk about it helping with fatigue? So a little bit of a longer question, but I would say that with fatigue, my first question is, how well are you sleeping? Because if you're not getting restorative sleep, like it's quite possible that that's contributing to the chronic fatigue during the day that you're experiencing. And you can have fatigue anyways for many other reasons. So I would say cannabis can help with sleep. And some forms of THC, sativas, can be stimulating or energizing, some patients will say. And so, so yes, I would say that's probably the best way to say how it does help with fatigue.
Thank you for such a fantastic, I learned a ton today. It's amazing.
So much.
So for people who are wondering, Caroline, Dr. MacCallum is being very informal here.
I know. I was like Rick, and I was like, oh shoot, I should have called him Dr. Arsenault.
Is back with us on October 16th. And then she and I will have a conversation about how you guys can access more of her extensive knowledge, either through us or through the Greenleaf Medical Clinic. Thanks again.
Yes. Yes.
Have a great week, everybody.
Thanks, everyone. Have a great day.